a study by Dan Weintraub, who's at the University of Pennsylvania, and others that work with him. But looking at the motor scores on the Parkinson's rating scale, there's a pretty good correlation with quality of life and how someone's doing that you can see there from the motor score, 0.56. However, the Hamilton Depression Scale, the Structured Clinical Interview, Geriatric Depression, they all have similar values to the motor score. How about disease duration? Not as well correlated. How about cognitive impairment? Not as well correlated. Sleepiness? Not as well correlated. Apathy. But depression certainly is a big feature that impacts their overall well-being. And if you can make that better, you can help a lot of patients. Okay, so how about dementia and Parkinson's disease, and what are the signs and symptoms indicating need for dementia evaluation? Well, as in most patients that have cognitive impairment, whether it's Alzheimer's or other problems, looking for new forgetfulness, trouble understanding spoken or written communication, language difficulties that is, difficulty finding words, that's pretty common in Parkinson's patients, even without dementia. They have a problem called the tip of the tongue phenomenon, where they know what they want to say, but they just can't get out the word. But then if you gave them a choice of 3 words, they go, oh, it's that one. They know exactly what they want to say once you say it. Not knowing common facts, such as the name of the current president, those kind of things, disorientation. I commonly ask patients, who's the president? What's he working on lately? So, I should get Obama and healthcare. Where did he go? Where's the last plane crash? What'd you have for dinner last night? Those kind of things. Another good bedside test is naming animals, animal fluency. The average patient should be able to name about 15 animals in a minute or so. So that's a pretty neat test to do. Some patients don't go to the water very much. They may go to the barn and the house and occasionally the air for birds and stuff like that, but they may not name the water. You'll see neat strategies that patients use to pick out those animals. Some psychiatric symptoms can occur in dementia as well. Depression can precede dementia in patients or be associated with it. They can be suspicious or paranoid sometimes. Anxiety, insomnia, hallucinations. Hallucinations are a harbinger of dementia in many cases. Personality changes with withdrawal, easy frustration, explosive spells, inappropriate friendliness or laughing inappropriately. That's called pseudobulbar affect, where you laugh when you shouldn't be laughing, like laughing at a funeral or at something sad that happened, or crying when you are happy and you're not sad at all. So pseudobulbar affect can occur in Parkinson's and other forms of Parkinsonism. Problem behaviors. In advanced patients, they may wander, get agitated, restless, get out of bed at night, fall in an advanced state, so that's a problem. And a lot of changes in day-to-day functioning, trouble driving, getting lost. There's a lot of visual spatial deficits in patients with Parkinson's that occur, and it can certainly affect driving and other tasks, difficulty handling money, etc. Well, one of the biggest aspects that is impaired in Parkinson's disease, probably more so than in patients with Alzheimer's, is executive dysfunction. That is planning, initiating, sequencing tasks, going from A to B to C to D in some sort of task, monitoring and shifting responses. These are frontal lobe dysfunctions. Even in patients that don't have dementia and that we're taking to deep brain stimulation, usually the average deep brain stimulation patient has 10, maybe 12 years of disease. Even in those folks that we take to DBS without definite dementia, who are good candidates for surgery, they actually have significant frontal lobe dysfunction. Okay, not qualifying for the big D, but it's there. It's a very common feature of Parkinson's patients. Visuomotor and visuospatial skills, drawing a clock, drawing a cube. You'll see problems with that. Going from A to B to C to D in a trails task. I'll show you that. Free recall memory can be impaired, and as I mentioned, the facts are frequently there for memory in PD, unlike Alzheimer's disease, but they have poor retrieval. It's there, but they can't pull it up. You give them a set of choices, they can choose it. Language is usually quite preserved, unlike Alzheimer's. Alzheimer's folks may say, I went to the door, when they meant to say, I went to the store. They'll screw up letters and have paraphasic errors. Parkinson's patients don't really have that much. Years ago, in the old school days, folks thought that the lifetime prevalence of dementia was about 25%. Now estimates are much higher due to better criteria and more application to patients earlier. And we think that in many studies now that up to 80% of patients, if they live long enough with Parkinson's, get dementia by death. Dementia has a lot of features that influence treatment in these patients, and we'll talk more about those. PD patients are actually 6 times more likely to develop dementia relative to the general population, according to a study by Karen Marder. Okay, next question. Which of the following non-motor problems is a major harbinger of dementia and markedly increases the risk of nursing home placement? Depression, visual hallucinations, constipation, or impaired olfaction? What do you think? Answer away, didn't I? Good job, guys. Exactly. Visual hallucinations are a very important harbinger of dementia in patients. Now, not all patients, but if they're quite elderly and they start hallucinating, commonly that's the first step in the door. Certain drugs in Parkinson's disease are associated with more visual hallucinations. For instance, dopamine agonists are much more likely to cause visual hallucinations than levodopa in patients. So if you see that in a patient's medication list and they're hallucinating like crazy, pull off the dopamine agonist in practice and actually use levodopa instead. And you may have a problem titrating out the motor symptoms to improve the hallucinations, but eventually you can get it titrated out where levodopa is balancing the loss of the dopamine agonist. So important feature there. So the risk factors for dementia and Parkinson's include early hallucinations. I mentioned that. We just did a question on that. The folks who are the stiff, rigid types with Parkinsonism, not the folks who have a lot of tremor. So you may see some PD patients who are just shaking like a leaf the entire time in the office on both sides, very large amplitude tremors at times. The tremulous Parkinson's patients are less likely to dement than these really stiff, rigid folks. About 25% of PD patients are thought to not develop tremor at all during their disease course. So these akinetic, rigid folks are certainly at higher risk, and that's been shown in numerous studies. Older age of onset. Aging and male gender have been consistently shown in studies to increase your risk of developing dementia with PD. And the severity of PD symptoms, as the PD progresses and gets worse, you're more likely to get it. Well, you always should rule out other causes of dementia in PD patients, and certainly delirium is important to exclude. Do they have new renal failure that's making them have cognitive impairment? So check their electrolytes, BUN and creatinine, etc. Medical illnesses like have they had a hip replacement and they're in the hospital and on narcotics, drugs? Can certainly make a lot of patients go whack and lose it, and they may have underlying dementia. But certainly you need to assess them in their best state off of these mind-altering drugs. Certainly for any patient that you suspect of having dementia, you should rule out hypothyroidism by sending a TSH at least, checking B12 levels to rule out B12 deficiency, and at least send an RPR or other test of choice for syphilis to rule out that. Certainly I do that in every patient, even a nun, because you just never know. But head CT also is indicated in someone you're ruling out dementia as well, because you can have multi-infarct states that lead to dementia, subdurals, or even rarely brain tumors or masses that can affect cognition. So there's in the further diagnosis of dementia, besides the bedside stuff that you can do, neuropsychological